It's Chris Wallis here from SUO 2023, and I'm pleased to be joined with Dr. Arvin George speaking about his recent presentation at the plenary session looking at focal therapy approaches in localized prostate cancer. So thank you so much for joining us.
Thank you so much. Really happy to be here.
So can you walk us through a little bit what you presented today, and maybe, this was early data, obviously looking just at really tolerability outcomes, but where you see maybe as the second part, where you see the field going. We can start first with the data we've got so far.
Yeah, the trial I presented today was really done in partnership between industry, which was Angiodynamics, but with the SUO CTC, or Clinical Trials Consortium, to be able to help accrue sites and build the evidence base for focal therapy. So I think that, one take home is that it's exciting times when we've kind of rallied around as a specialty to start building some evidence in focal therapy specifically. And this trial was the FDA trial for prostate tissue ablation using the 510K approval mechanism, or having a substantially similar predicate device for irreversible electroporation, and it was mainly done in an intermediate risk prostate cancer population. So while I wasn't able to present oncologic data yet, I think what we have seen is that, as expected, just like all other treatment modalities in the focal space so far, that it is very well tolerated, has an excellent morbidity or toxicity profile, and we'll, I think, in the coming months, we'll learn a lot more about its functional outcomes as well.
So we've seen, IRE is not really new. It's maybe a bit new in the U.S., but has been used other places. And so if you try to project forward a little bit, how do you think it's going to land? Do you think is this all similar to other focal therapy modalities, or is there a particular clinical benefit you can sort of draw from your experience about why this may be a preferable modality?
Yeah, all different energy modalities in the focal ablation space. I think ultimately that different cars all getting you to the same destination at the end of the day. Now, each of those will have their unique benefits, right? So, you have a Tesla, which will maybe get you from point A to point B much more quickly, but you may have to make a stop to charge, right? You have a Toyota Camry that will get you from A to B, and it's, old faithful and it's reliable. And similarly, when I look at IRE specifically, I think there are some unique aspects of it where it may be preferable over other treatment modalities. So specifically, the lack of a reliance on a fixed thermal effect. So either like freezing it, like with cryotherapy, or with HIFU or laser ablation, which is again using thermal fixation but heating up the tissue. While there is a little bit of thermal dispersion that will happen around the electrodes itself, it's largely an athermal procedure, and that can pose a real advantage when you're close to structures which may result in thermal sink. So the use of a cooling catheter, a warming catheter during cryotherapy, or close to the bladder neck, or close to the DVC, which can siphon off energy and not allow you to reach the lethal temperatures that you like. It's also, I would say, a relatively quick procedure. Now, the placement of the needles need to be pretty precise, but after that, the treatment itself moves pretty quickly. So I think that it will have its place, just like with all the other technologies as well.
Absolutely. So maybe you can tell us a little bit about the inclusion criteria in this trial, and that to some degree dovetails into the question of who is the right patient for this kind of a treatment approach, and how does it fit on the spectrum from maybe surveillance on one end, and we heard a lot of criticism of focal therapy being compared or assessed in patients who really ought to have been getting surveillance versus more advanced disease that really needs a whole gland approach.
Yeah, this is a really important question, because what we think of when we're trying to identify a patient population now, we are also making the assumption that that population is going to be relevant 5, 10, 15 years down the line. We did see a prior presentation by Dr. George Shade, who presented some of the data regarding photodynamic therapy, which ultimately was not successful in the United States. It was a randomized clinical trial, but it was comparing it to surveillance. And so now that we understand the biology of the disease, we really understand that patients who are strong surveillance candidates, especially in the low-risk population, that they aren't going to be a good candidate for any treatment, because any morbidity, however little it is too great if you're not going to really achieve any sort of oncological benefit. So for this trial specifically, we tried to focus in the intermediate risk category. We don't know enough about high risk yet, and so we wanted to start within a patient population we feel has a potential benefit, and where there's uncertainty regarding that benefit. There are many men with Gleason 3 favorable and unfavorable intermediate risk prostate cancer that will not metastasize, that may ultimately never die from that disease with or without treatment. We know that from the PROTECT and PIVOT trials. And so what we did focus on the Gleason 3+4 and 4+3. We did put some guardrails up within those categories as well, allowing for a PSA density up to 0.15 if the PSA exceeded 15, or a hard cutoff of PSA of 15. Had to be organ confined, at least based on conventional staging, based on imaging, of course. And so far, I think the accrual was quite successful, really supported by the SUSCTC sites.
Absolutely, and as we think about patient counseling and where this fits in an armamentarium, how do you counsel patients regarding the notion of focal therapy or whole gland? What's the principle, I guess, is you're trading off a bit of uncertainty about oncologic efficacy against preserving function, and how do you approach those conversations?
Yeah, so I think that at this stage it is critically important to be extraordinarily open and transparent with these patients. So all of my conversations when I'm counseling patients start out with, this is not the standard of care, and this is the reason why. This is what we don't know, this is what we do know. And then once you talk to them about its relative place in terms of the short and intermediate term outcomes that we do have, you don't ever need to convince a patient to pursue a minimally invasive procedure that preserves continence and erectile function. That's an outpatient procedure with minimal convalescence time. In fact, it's oftentimes more of a challenge to convince somebody who has their eyes set on a minimally invasive procedure and they're not an appropriate candidate. I find myself oftentimes spending more time with them trying to explain to them the reasons that they're not an appropriate candidate and how applying this treatment is not going to align with what their ultimate expectations or goals of care actually are. So my advice in summary is be extraordinarily transparent about cancer outcomes, retreatment rates, morbidity. What are the options after recurrent disease in focal therapy? What does that look like? And so those are all really important considerations to discuss with the patient. And once they have a fully informed mindset, as long as you're carefully and responsibly choosing these patients, I think that it's important to be able to track them very closely. So either within a clinical trial or a prospective registry, we have all of our patients are enrolled in a prospective registry so that we can measure their outcomes closely.
So that leads into sort of my second to last question, which is how do you follow these patients? What does a post-treatment surveillance look like? And, maybe your thoughts on the importance of post-treatment biopsy, because I know we're seeing, in protocols, it's nearly always mandated. But when we looked at, I'm practicing in Canada, there's a bit more diffusion of this technology, and we're seeing a lot of people out there not doing post-treatment biopsy. So what's your approach to monitoring these patients after treatment?
Yeah, I follow the kind of the guidance of the Kyoto Consensus Statement that was really published in support by the Focal Therapy Society. It was a Delphi Consensus Statement which looked at the interval at which you would follow men and how you follow them. But typically, it's going to be with PSA, with imaging, and for me right now, biopsy. At least in the United States, I think one of the greatest questions is the oncologic efficacy. And so if we are going to be able to address that, or at least allay the concerns for both patients, for payers, for those decision makers who put these treatments in guidelines, I think we need objective histologic evidence that shows treatment efficacy. Now, whether or not that ultimately aligns with the outcomes that are most important, that would be metastasis-free survival, disease-specific survival, overall survival, we will get there eventually. And we have multiple prospective randomized trials now on the way to addressing those. But in the near term, I follow patients with PSA every 3 months for the first year, every 6 months for years 2 to 5, and every year after that. Of course, I would modify the frequency of that dependent on the outcome. from an imaging perspective, I perform imaging and a biopsy at 6 months, imaging, and then after that, my biopsies are subsequently only for cause. But I will repeat an MRI image at 2 years and 5 years post-ablation as well.
Absolutely. So my last question then is, you alluded to the fact that when you counsel patients, you don't consider the standard of care right now, and it's not, a guideline recommended treatment. What more do we need? What information does our community need to move focal therapy from an experimental treatment into something that you consider, routine care or guideline concordant care or standard of care?
Yeah. So the purest answer is that we need randomized controlled trial data, and that is coming, but I don't think that's going to stop this train. And so I think we need to learn from what the data that we already have and real world data that we are accumulating in real time. There is value to real world data. To say that real world data does not impact our decision making in any way, surveillance, the implementation of surveillance was based on prospective real world data. And so I think in the long term, it's going to be the trial data that solidifies it. In the near term, it's going to be conceptually the acceptance of, as we talked about it previously, focal therapy as a philosophy, as a cancer management strategy, where not every patient necessarily requires cure, but rather be able to, prevent that lethal clone from being able to continue to develop or progress. But I think we're close. I did say it's not the standard of care, but I did not say that it's experimental, because I don't believe it's experimental anymore. We have tens of thousands of cases that we have experience with various technologies, with HIFU, with cryo, with irreversible electroporation, with laser ablation. And so I think it would be naive to say that it's an experimental therapy, but I do still think that there are a number of questions that need to be answered.
Well, thank you so much for your time. Really, really appreciate your insights.
Thank you so much.